to be adjusted in a sharp focus on the retina. Where in the retina? Exactly at the macular area in the retina, which is the center of the visual perception center. And finally, in the fovea. Fovea is the center of the macula. Then sent to the brain to see the object. Eye to form a sharp focus and image. Then the higher centers in the brain to receive, analyze, and translate the image of the object by the higher centers, by the perception centers, and by translation centers, which is the visual area and visual accessory of visual centers in the brain and the cortex. The visual pathway is a connecting pathway. You know what's meant by the visual pathway? Visual pathway means the part which connects the eye with the higher centers in the brain. It starts from the retinal fibers forming the optic nerve, then through the posterior part of the optic nerve, then optic chiasma, and then the divergence or the divisions of the visual pathway to both right and left visual centers in the brain cortex. Light rays are modified while passing through cornea and lens. Light rays are modified during this process. This modification is a phenomena called refraction. So refraction means how to adjust the light rays, how to collect the light rays by the different surfaces, by the different phenomena to form the image in the sharp way or the sharp manner at the end. This word is called refraction. So what's the meaning of the refraction, or the word refraction? Means modification of the light rays while passing through the surfaces of the eye. The refraction is done actually by the eye surfaces, mainly cornea and lens. So there is no rule in the for the visual pathway in the refraction. There is no rule for the brain centers in the refraction. So refraction is an optical phenomenon. Refraction of the light rays should be done in order to be a single point, not two, to see clearly the image or the objects. So refraction means formation of a sharp focus, which is one focus, should be one focus, not to be two foci or different foci. Otherwise, if there is multiple foci, the visual acuity will be blurred, or I mean the vision will be blurred with no clear objects. So from this slide, you have to know that there are different stations for the vision: the object, the light rays, the ocular surfaces responsible for the refraction, and finally the visual pathway and the translation and the explanation of the vision by the visual centers in the brain. To know the anatomy of the refractive system of the eye, look at this slide. You will find it as a cross section in the globe or in the eye itself. The eye components are cornea, lens, and I marked them in this green color to know that they are the principal surfaces of the eye responsible for the refraction. Then retina, macula, fovea in red because they are neurological or neuronal fibers responsible for transformation of the light energy, which is a thermal or physical energy, into electrical impulses to be sent by the nerve to the brain. And finally, the optic nerve, which carries this impulse to the visual centers. But you have to know an important fact, which is that the media should be transparent. If there is no transparency in the cornea, the vision won't be good. If there is no transparency, the lens won't be good again. And finally, if there is no transparency in the vitreous cavity, which is space through which the light rays will be passed, conveyed to the to be a sharp focus on the retina. So if there is opacity in the cornea, in the aqueous, in the antechamber, I mean, if there is opacity in the lens, if there is opacity in the vitreous, the vision will be interrupted. So refraction, to be done perfectly, the all media through which the light rays are passing should be transparent and clear. The total refractive power of the eye is 59 diopters, and divided in this way. The uh, the cornea is around 45, 43 to 45 diopters, and the remaining is for the lens. So if you calculated this power, you will find that 59 minus 43 or 45, which is that of the cornea, you will find that the power of the lens is much less than the cornea. So the patient can see with the cornea even if there is aphakia, if there is no lens, he can see, but very blurred vision. So adding plus lens from outside the glasses to compensate for the loss of the lens. ماشي. عاوز بس تبقى متابع معايا لو في أي حاجة في الصوت، لو في أي حاجة في الصورة تعرفني، وعشان يعني نبقى continuous with each other. يبقى total refractive power of the eye يعني to keep it in your mind is 59, 43 to 45 of them is for the cornea alone. Okay, and the remaining part, which is around 13 to 15, I think, from 14 to 17 diopter is for the lens. It's an average. Uh, the numbers down in the photo is for the optical, is for the refractive index. Refractive index means the ability of the media to refract the light. The light in the air with refraction different than the light in the water or the fluids like aqueous in the glass in the corneal tissue. So the refractive index in the air is 1. So 1 to 1 equals 0. So the light rays passing in the air with no refraction. The air, it doesn't refract the light, so the light passing with no change in the direction. But you will find that the light rays is changed while they are passing through the water. لو انت يعني looked at an object in the water from outside, you will find that this object is somewhat closer and somewhat tilted because the light refraction, sorry, the refraction of the light is different in the water than in the air. So we'll find that the image is different when the object is put inside of the water, because the aqueous humor, which is equal to that of the water, is 1.33. And look at the cornea is 1.38. Aqueous 1.33, lens 1.4, and finally the vitreous 1.34. So the most powerful regarding the refractive index is the lens 1.4 refractive index. So the power of the cornea is not the refractive index. The power of the cornea is the convexity of the surface and the integrity of the corneal stroma. But the least refraction, no refraction in the air. After that, the least refraction is in the aqueous humor, is 1.33. The next vitreous, because of vitreous is viscous, so it's denser than the aqueous, so 1.34. But they are mostly equal. The cornea and lens, mostly equal, but the lens is more powerful in the refractive index. I mean, so differentiate between the two terms, refractive power and refractive index. Refractive index means the ability of the capability of the media to refract the light, to change the direction of the light, either outside or inside, outwards or inwards. Outwards means divergence, and inwards means convergence. So I don't like to disturb your mind, to put a lot of information in your mind today, just emphasizing and focusing on some terms to know. And you have to know these terms because they are the basic background regarding the optics of the eye and refraction of the eye. Okay, here in this image, or the original image, very important point to know that the pupil, which is the circular opening in the center of the iris, is very important organ in the refraction, which means that the constriction of the pupil will limit the entrance of the light rays. So it will allow the entrance of the central light rays, which is which are subjected to the least refractive power of the surfaces. So the image will be collected directly on the retina in the fovea or the macula to give you a sharp, clear image. But if the pupil dilated, like in case of the dark vision, in the cases of the dilatation of the pupil by the eye drops, it's called dilators. Eye drops like tropicamide, like cyclopentolate, like atropine. You'll find that a lot of very huge amounts of the light rays will enter the into the eye from the peripheral parts. So a different types, different powers of refraction. So the image will be less in clarity because of the shadows and glare and the halos from the refracted light rays at the peripheral part of the lens. Look here at this diagram, you'll find the lens, you will find that the cornea, the surface of the cornea, is not the same at the peripheral part. Also, the lens, the surfaces of the lens, especially the posterior surface, is not like the central part. So the refractive powers will be different in the periphery than the center. So on pupil dilatation, the light rays will be subjected to a different kinds of refractive powers, and so giving you finally a less clear or a hazy or blurred image. So the pupil constriction is a protective function and also increasing the refractive power and the refractive potency of the eye. قلنا السلايد دي خلاص. This is a diagram showing how the light passing through the central part of the cornea and the lens as well. The the uh, the going in and going out. The going in is called P1, P2, and P3 and P4 is the reflected. There is reflected light rays, you know. Uh, the reflected lights from the corneal tissue and the reflected lights from the lens tissue is a minimal part, but more than 95% of the light rays passing through the surface will enter to the retina, while around 5% to 10% will be reflected from the tissue fibrils, the collagen fibrils, and the proteins present in the lens. What's the function of them? The function of them, it's called firstly light scattering. Light scattering means that the light rays will strike will strike with the fibrils, with the collagen bundles in the cornea and protein sheets in the lens, and they are reflected outside again. It's around 5 to 10%, as I told you, but they are very important on examination to see the cornea and to see the lens. So normally, normally there is around 10% of the light rays reflected back outside of the eye because of a phenomenon called light scattering. This light scattering is responsible for seeing these objects on examination. On the slit lamp, when I'm going to examine a patient on the slit lamp, I wouldn't be able to see the cornea or to see the lens if there is no light reflection. Like light reflection means reflection means reflection going back. Reflection means reflection is different than refraction. To know, refraction means the light will continue its pathway, but with some change in the direction. But reflection, it is the mirror function. Reflection means the light will be directed back to you. Okay, the same like if you hit the wall with a ball. If you throw a ball to a wall, this ball will be directed back, will come back to you again. So it's called reflection. Okay, but refraction, if you throw the ball through the window, open window, the ball will continue its way to outside. So you have to know the difference between two expressions, and and you have to know the function or the purpose of this reflected lights. When you examine the cornea by your torch or by a slit lamp examination, you will be able to see the cornea by this reflected light. Otherwise, the cornea will be nil. You will not see anything. You cannot assess, you cannot judge the cornea or the lens as well. Again, again, this phenomena I told you about, which is the reflected light, is the same as what's called Purkinje images. You know the Purkinje image phenomena, that the reflected light from these surfaces will give you a mirror image on these surfaces. So the Purkinje image, yeah, I draw this pathway of the light reflection to all of you. But the Purkinje image, before going to this, I if you put an object in front of the eye like a lighted candle, you will see them on the ocular surfaces. You will see how much, or I mean how many images for this lighted candle will be seen. Count with me. The front surface, one. The front surface of the cornea, one. The back surface of the cornea, two. The front surface of the lens, one. The back surface of the lens, two. So normally you can see four images for these candles, for this lighted candle into the patient's eye, because of the reflected part of the light rays. But the front surface is convex, so you will see the object as an erect in its normal position. The back surface is concave in the lens, in the cornea. I'm sorry. So the image will be inverted upside down. The front surface in the lens erect, the back surface in the cornea, the back surface in the lens again, like the back surface of the lens. So three images or four images according to the dilation. If the pupil is not dilated, you will see just three images. If the pupil is dilated, you will see four images. Okay, one of them is inverted and the other is erect position. Okay, I think it's clear now. So this is the Purkinje
Yes.
image.
Yes.
Okay, thanks so much. Here it's a summary for the all information needed to know about the cornea and the crystalline lens as refractive surfaces. Cornea is a main refracting surface I told you about, provides 40 diopters. Uh, ولكن في in some textbooks you'll find them as 43 to 45, but an average of 40 diopters, or 75% of the total refracting power of the eye, all two-thirds of the power of the eye. يعني in different explanation, different terms. 40 diopters, 75, or two-thirds of the power of the eye. The lens double purpose here in refraction, balancing eyes refracting or refractive power and providing a focusing mechanism. The cornea is not moving, is a, is a uniform, stable surface, but the lens is moving because of the zonular contraction and the ciliary muscle contraction. So the power of the lens is different from in different situations. I mean, because the lens is dependent upon the accommodation power with the ciliary contraction or ciliary relaxation. So the lens size is changeable. And because the lens size is changeable, the surfaces will be in different modes. According to the mode, the power will be in the refraction. So it's different. So I told you about that the lens is from 14 to 16 diopters, and this slide I wrote it 20 diopters. It's an average, but it may be changed because of the refractive power or the accommodative power of this eye. So the refraction of the lens is changeable, but the refraction of the cornea is fixed. This is another information to know. Double purpose for the crystalline lens is the refraction. Firstly, the refraction of the lens, the refraction of the light. Secondly, focusing the mechanism to make the person able to see the near objects. So when you are trying to see a far object, you will see by both surfaces while they are relaxed. But as the object getting closer to your eye, the 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 um, the angle of the light rays coming from this object will be changed, will be more obtuse. So the light rays will be diverted more and needing to be converged again. This function is called the accommodation of the eye, and this function is done totally by the lens. Totally by the lens. So in old age, while the lens is less elastic and uh, is more tough tissues with less power of the relaxation or the focusing mechanism of this lens, so the patient or the person won't be able to see the near objects, which is called presbyopia. And then we will need to add some plus lenses or reading glasses to help this person to see the near objects. Okay. وعشان كده انا كتبت لك in the third line the cornea is fixed, but the crystalline lens is changeable, and this changes depend on how far the object is from the eye. وهنا طبعا تحت خالص في slides you will find the anatomy of the lens and anatomy of the eye and a photo for the cornea. In children, the power of the cornea 32 diopter. It reaches the maximum power at the age of 18, which is 40 diopter. So 18 is the age of vision stability. So in our career, we are going to do refractive surgery like LASIK, ICL implantation, or other means at the age of 20 because it's the age of visual stability or refraction stability. That's why it's not recommended to do any refractive surgery before age of 18. At age of 40, they will have presbyopia. At age of 60, there is no accommodation, zero diopter. I mean the accommodation. Okay. Now, on the physiology of the vision, next part is the physiology of refraction. When light rays travel from a medium to another medium with different refractive index at the boundary between the two media, the wave phase velocity is altered so that light rays change their direction. يبقى put in your mind there's difference between the refractive power and the refractive index, and the 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 surface between two indices or between two surfaces at which the light will change the direction because of the different refractive index. وحفظنا مع بعض ان the refractive index of the air is light, refractive index to the light in the air is 1 diopter, which means zero refraction. And the cornea is 1.33 in 1.38 aqueous 1.33, in the lens 1.40, in the vitreous 1.34. Okay, the amount of refraction depends on the refractive index and the angle of incidence. So I told you about the position of the place and distance of the object from the eye. As the object is coming closer to the eye, the angle of incidence is higher and so needs more refractive power. Refraction direction depends upon low to high towards the central line, which is convergence, or high to low away from the central line or divergence. So refraction is either from a low medium to high medium, so it's going to be converged to going in, or coming from high medium to low medium, so going to be diverged or being divergent and going outside away from the central line. In these photos, you will see different examples I told you about while passing through the last slides. Unit of refraction is diopter. The total eye power is 59 or 60 diopters for distance. We will focus with the relaxation of the accommodation is at 6 meters. يبقى معناها when I ask you about the eye power, the eye power of refraction, you will told me in this way 59 to 60 diopters, but you have to say but the object should be at 6 meters. And you have to continue. As this object is coming closer to the eye, the refractive power of the eye should be increased. And this increase in the power will be performed by the lens, not the cornea. Okay? Unit of refraction is diopter. This table also showing the difference of the focusing power for far and for near. Viewing a distance object 6 meters or more, you will find that they are going to be in the same direction. Angle of incidence, part of the eye, and sharp focus at the end. Nearly parallel light rays, because they are coming from a far object with angle of incidence very low. So the light rays are almost like straight and nearly parallel light rays. But in near objects like focusing this computer now while we are studying together, you will find that the light rays are coming from a closer point, so higher angle of incidence, so the light rays will coming more divergent, and so we need to converge this divergent light rays, so we need more power. I think it's clear now for these words. And let's go for the accommodation. The accommodation power is very important phenomena and very important function in the eye. Is done by the lens, but actually there are accessory organs like the zonules, which are attached to the ciliary muscles present located at the ciliary body. So the ciliary muscle contraction will will withdraw, will do traction to the lens by the zonules or relaxation of the zonules. So stretch or relaxation of the zonules will control the shape and the power of the lens. Uh, What's the explanation of accommodation according to the Helmholtz theory? When the eye looks at close object, contraction of the ciliary muscle will decrease the tension in the zonule fiber. Relaxation. So contraction of a muscle means the relaxation of the zonules. The, 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 the reverse, okay? Put in your mind. Lens is more spherical and powerful. Contraction of the muscle, making them closer, contraction of the muscle, making them closer with the relaxation of the zonules. So the stretched zonules will be relaxed, so the lens going to be more spherical with less stretch. Okay? Contraction of the ciliary muscle is supplied by the parasympathetic third nerve. يبقى the nerve responsible for the accommodation is the third nerve, parasympathetic fibers of the oculomotor nerve. After prolonged reading, there might be ciliary spasm associated with associated headache. So we are recommending for the all persons to get break after 45 minutes of reading because of what? To relax the accommodation and to avoid getting athenopia, which is called the ocular pain due to accommodation spasm or ciliary muscle spasm. And all events happening in the accommodation, you'll find them in the right side of this table. Look at change of the lens shape and meiosis. Meiosis also helps in the in the process of accommodation. Why? Because meiosis will limit the divergent rays to enter the eye and will allow the parallel rays in the center to enter the eye to help forming a sharp focus on the retina. Meiosis will be done by also by the parasympathetic nerve fibers of the oculomotor, which supplies the pupillary muscles. I mean, also there is what's called convergence. The third event is convergence, which is done by the contraction of the medial recti muscles. So the accommodation events are three: change of lens shape by the ciliary muscle contraction, parasympathetic third nerve, meiosis allows much light rays as possible to enter in the center, parasympathetic nerve, parasympathetic fibers of the third nerve, and finally the convergence by the medial recti, which is by the motor fibers of the third nerve. We're in, excuse me, we looking at an object at 6 meters means that there is no accommodation, mostly no accommodation. The accommodation will be zero in this situation. So going to the errors of refraction. We talked about the refraction, physiology of vision, physiology of refraction, the refractive surfaces, and the phenomena of refraction. Now, the errors of refraction, important terms. Emmetropia, ametropia, and presbyopia. Emmetropia means there is no error of refraction, means that the refraction of the eye is normal. So the patient can see see objects at 6 meters as clear objects. It's called 6 to 6 or 20 to 20 by the American way. Okay, So emetropia means that the refractive power of the eye is normal and there is no errors of refraction. Ametropia means that the patient cannot see the objects properly and clearly at the normal distances. So there is an error of refraction. And finally, the presbyopia. Presbyopia means inability of the person to see the near objects, especially after the age of 40, due to the loss or the weakening of the accommodative power of the eye. It's physiological process and age related. Okay, this is called presbyopia. To differentiate between the errors of refraction and presbyopia. Presbyopia, it's not an error of refraction, but actually age-related change in the refraction. But ametropia happens at any age, okay, and should be in the younger age. So ametropia means error of refraction, which could be myopia, hypermetropia, or astigmatism. Myopia, we will discuss, hypermetropia we'll discuss, and the astigmatism, which will be regular or irregular astigmatism. Regular regular astigmatism means that the all meridian in the corneal curvature is different than the other, but the all meridian. But irregular astigmatism means that there is a part of the meridian is different irregularly than the other meridian, not the all meridian. Irregular, with the rule astigmatism, you will find in the with the rule astigmatism that the vertical the vertical meridian is steeper than the horizontal. Against the rule, you will find that the horizontal is steeper, yani more curved. Steeper means more curved, yani steeper means more convergent and more curved with higher power. Okay, uh, so steeper vertical is with the rule, steeper horizontal is against the rule. In these photos, you will find that there are a different uh, situations. A point at the retina. This is the normal one in the emmetropic eye. But focus in front of the retina in the myopic and theoretically behind the eye in the hyperopic eye. Okay, so let's go. Myopia is either refractive or axial. Myopia means short-sightedness. يعني إيه myopia? Short-sightedness يعني the person can see the near objects while the far objects are blurred, cannot see. Either refractive or axial. Axial means that the axial length of the eye, which is the distance between the corneal vertex or corneal apex and the fovea. This axial length is longer than normal. So what's the normal? The normal is around 24 millimeters. The normal in the adult is 24 millimeter. Less than 24 is called short eye, and more than 24 is called longer or long eye. So axial myopia means that the axial length of the eye in myopia will be more than 24 millimeters. So the travel of the light rays will will end before getting the fovea. The focus will be formed in front of the fovea because the longer axial length. So it's called axial myopia. But if normal axial length in myopic patient, so it will be called refractive myopia, means that the corneal power is higher than the normal, is higher than the 40, is higher than 43. It accounts around 50 or 55 diopters in some cases. So the increased refractive power of the cornea than normal or increased refractive power of the lens than normal will cause this myopia. But to differentiate the difference between the refractive myopia and the axial myopia, that the axial length in the axial myopia is longer than 24, and the axial length in the refractive myopia is within normal, which is 23 to 24 millimeters. As I told you now, the refractive myopia is either corneal or lens power is higher than normal. Steep cornea could be in normal person or in pathology called keratoconus. Spherical lens, more, more globular lens, so the refractive power of the lens is higher than normal, like in microspherophakia. There is a congenital anomaly called spherical lens or microspherophakia, or osmosis or hyperglycemia as changing in their refractive index. Osmosis, hyperosmosis, or hyperglycemia, which increases the blood sugar inside of the lens, will increase the refractive index and the refractive power of the lens, as I told you before, so will cause more refractive power to the lens, causing what's called refractive myopia. Means that the travel will be shorter than the will be shorter. The travel of the end station will be located in front of the retina, not able to reach the retina. And nuclear cataract. It's called index myopia or refractive myopia as well. Increased refractive index of the nucleus of the lens in the nuclear cataract, causing what's called induced myopia. It's not actual myopia, but induced myopia. So when you remove this cataract, will remove this increased index, and then the patient will be able to see clearly again. So, as an undergraduate, the basic science of the refraction will be just for this information. Myopia, short-sightedness definition causes or types refractive or axial. Axial means, as you see in the photo, that the axial length is longer than, it's called axial myopia due to longer axial length. Then what? Than 24 EVS. So the normal in some textbooks from 22 to 24, 22 to 24 millimeter. 21 is short eye. 25, 26, 27 is long eye. Okay. Other type is refractive. Refractive will be for two refractive surfaces, corneal and lens. So the corneal refractive power, high curved, high steeper cornea, as in normal persons or keratoconus, or the lens in spherical lens as microspherophakia or hyperglycemia on the nuclear cataract. What's the cause? Is increased refractive index and in turn refractive power of the lens. The other type of errors of refraction is a hypermetropia. Hypermetropia means long-sightedness, but it's not like the what's called hypermetropia طول النظر in Arabic. It's called طول النظر, but uh, most of patients when they hear this word, and you should know differently than the general population, when they hear this word, they are asking, so doctor, I can see the far objects well and clear, while the near objects blurred. I mean that I have a good vision and better vision because I have plus more vision. No, it's actually not, because hypermetropia means that there is an error of refraction which makes the vision blurred. But the blurring for the far is less than the blurring for the near. So it's called long-sightedness. So the patient prefers to see far than near because there is an error with the near vision. But in myopia, the patient can see the near objects clearly, while the far objects are blurred. Okay, so the difference here. But hypermetropia, it's not supervision, it's not plus vision. It's actually an error of refraction. The same types of hypermetropia. Axial. I told you in myopia is axial is D2 longer eye. So yes. So in hypermetropia, axial hypermetropia will be D2 shorter eye. So the axial length, as you see in the photo on the right side in hypermetropia, the axial length is shorter than the normal eye. When I ask you, what would be the axial length in such case, you will say that it's less than 22 millimeter. We adding to your information that the cutoff point in the hypermetropia in the normal or the common hypermetropia is is 20 millimeter. Less than 19 or less is called micro microphthalmia. It's a congenital anomaly. So there is a great difference between the error of refraction in the hypermetropia and the or the microphthalmia. Microphthalmia means that the axial length is very short. It's shorter than or equal to 19 millimeter. So no, you have to know short eye is from 22 to 20. 19 or less is called short eye, very short eye, or what's called microphthalmia, which is a congenital anomaly and a very difficult situation in dealing with. Hypermetropia refractive is called corneal or lens power is less than normal. Means in myopia steep, here you will find flat cornea. Flat cornea. I'm sorry for mistyping. It's not keratoconus. It's flat cornea normal, but not in keratoconus. This is mistyping. Small or flat lens. Small or flat lens. Osmosis or hypoglycemia. في المريضة كانت hyperglycemia. هنا hypoglycemia will make the lens smaller and shrunk. So the refractive power of the lens will be decreased. So the refractive power of the eye will be decreased. So the focus won't be put on the fovea, will travel behind. Okay? The same cortical cataract في المريضة كانت ايه يا شباب؟ كانت nuclear cataract, nucleus. اما في الcortical cataract will make a rational change in the refractive power of the lens. In the cortical cataract, so the peripheral part of the lens in the cortex will make the light divergent because the cortical cataract will decrease the power of the nucleus. So the light rays will be more divergent. So when they meet again to form the focus, this focus will be behind of the eye. So to keep in your mind, hypermetropia, long-sightedness, the patient can see will see the images or the objects blurred for far and for near, but the far is less blurred than the near. Okay, types: refractive, cornea, flat. يعني what what the concept hypermetropia means less convergence, so the eye is with less power. يبقى against الميوبيا تماما. هنا كان steep cornea يعني more curved، هنا less curved or flat cornea. اللينس كانت larger or more spherical، هنا flat lens or small lens. الأسموزس كان هناك hyperglycemia، هنا hypoglycemia. هناك في الميوبيا كانت nuclear cataract with increased index، هنا cortical cataract with decreased refractive index of the lens. طب الاكزيال في الهايبرمتروبيا short eye، في اللونج في الميوبيا long eye. So before going to the next slide, how to treat how to treat. Excuse me, giving me just 2 seconds.
حاضر.
Omar, Omar, عليكم السلام. عليكم السلام حبيبي. كلام ايه ده حبيبي؟ قول لي. انا في محاضرة زوم دلوقتي. لا لا، انا في محاضرة بس الطلبة دلوقتي. قول لي. خلص كده. طب طب خلص واكلمك. حبيبي. السلام عليكم، مع السلامة. I'm sorry brothers. uh, في المستشفى بس، فقلت في حالة طوارئ أو حاجة. uh, let's resume again. So in myopia، لو أنا يعني about this question. In myopia the power is over or less. You will you will answer more or less. ممكن حد يجاوبني؟
More, right?
More. Perfect. So you need to decrease the power, right?
Right, yeah.
Yeah, okay. So we will use which kind of lens? Divergent or convergent lens? Hmm?
Divergent, I think.
What's the type of the lens to be divergent? Concave or convex?
Concave?
Concave lens. Perfect. So in myopia, you need to decrease the power, so you will diverge the raw light rays by the concave lens. Concave are divergent lens, convex are convergent lens. So but the concept myopia, more power, I need to listen. So I will treat the myopia with a concave lens in spectacles, which is glasses or contact lens type. The third line of treatment of myopia is a laser. So is the refractive surgery, I mean, by laser or lens implantation. So by laser, what I'm going to flatten the cornea because the cornea is steep or with high power. Even if the lens is a cause, even if the long axial length is a cause, I'm going to decrease the power of the whole refractive power of the eye. So I am using concave lens in the glasses or concave contact lens, or going to flatten the cornea to make it less curved by the laser ablation in the LASIK surgery. Okay, or finally to remove the high power lens to implant another lens to correct this myopia. يبقى the modes of treatments of myopia in order, please start in order. Concave lenses in the glasses or contact lens, or after the age of 18, as I told you, I will go for a refractive surgery in the form of laser ablation. Laser ablation will act as a concave lens. How? By flattening of the cornea. Or the second option of refractive surgery is lens implantation inside of the eye to change the power of the eye and correct this myopia. But lens actually يا شباب in the high errors minus 8, minus 10, minus 15, minus 20. In the high errors, the laser will not be the good option or the suitable option for such patient. But in minus 2, minus 3, minus 4, it's very easy to correct with laser ablation. Excimer laser. Which kind of laser? Excimer laser. Excimer laser. ليه بنستخدم excimer laser? Because it's the shortest wavelength. Shor- the shortest wavelength. Shortest wavelength, please. في بس noise. في noise in the background. طيب الهاي. Please brother. الميوت. ميوت. hypermetropia. the reverse. أخونا الفاضل قال لي إن هو will use the concave lens in the myopia. So we will use the convex lens. Hypermetropia means the lights are divergent, so I need to converge. So I will use a divergent, a convergent lens. Mean a convergent lens is a convex lens. So you will find that the patients when you see glasses, look at the lens. If the object's smaller, it's concave lens. If the object is bigger, is a convex lens. So convex lens put for the hypermetropia to correct the divergent lens and to increase لأن احنا عندنا الhypermetropia with less power, not more power. So I need to increase the power by increasing the convergence power of the eye by the convex lens. Spectacles, contact lenses, also the same for the refractive surgery options by laser to make the cornea flat ولا make the cornea steeper. لو انت فكرت انا عاوزها convex يبقى انا هخليها more curved يبقى I'm going to reshape the cornea to be steeper also by implantation of the lens in the high errors واحنا يعني we have a lot of patients with high hypermetropia like plus 10 or more, and you will find that these goggles will increase the will act as magnifiers. You will find that the eye is bigger behind this lens. The reverse with the high myopic patient, you will find that the eye is smaller. Finally, the astigmatism. Astigmatism means that there is different powers in the different meridians of the curvatures of the eye, but mainly the cornea. The astigmatism is either the two corneal cause, lens cause, or retinal cause. But the main is the cornea. Look at this photo on your right side. No astigmatism, regular astigmatism, irregular astigmatism. I think you can see the difference between. The first one with no astigmatism is spherical. All curvatures are the same, but in the middle there is a toric one, squeezed one, but squeezed regularly with the same balanced power. So there is a difference between the direction in the vertical and the horizontal meridians, but the vertical and the horizontal meridians change it but regularly in the regular pattern. So it's called regular astigmatism. But in the third one, you will find that there is prolapse from the side. So the change is irregular as you see. So simply the difference between the spherical cornea with no astigmatism, the astigmatic cornea with the regular, and the astigmatic cornea with irregular astigmatism. Principal corneal meridians. Now we are plotting the principal corneal meridians as vertical and horizontal in simple way. So when they are not equal in the refractive power, it's called astigmatism. If the vertical and the horizontal are equal in curvature and equal in the horizontal power, in the refractive power, so there is no difference. The refraction of the vertical is like the refraction of the horizontal. So the same power, so no astigmatism, because the focus will be one. But if the vertical is higher in power than the horizontal, so the refraction through the vertical will be more powerful than the refraction through the horizontal. So the eye will get two foci, not one focus. So it's called astigmatic eye. كلمة stigma means point. A means none, no point. Astigmatism, so it's one word. It's not a, which is the you know the a and the اللي هي البانكتويشنز او ادوات التعريف كما يقولون. Uh, but here it's a in Latin word. It's a Latin word. Astigmatism means no point. ويسموها باللغة العربية اللانقطية. كلمة استجماتيزم معناها اللا نقطية. استجماتيزم اسم دي اللي هي الايه الكونديشن او ال what's called الستيتس نفسها الباثولوجيكال ستيتس. So astigmatism means that the refractive powers of the eye are not equal in refractive power. What are the principal meridians of the eye? Vertical and horizontal meridians. Regular astigmatism means that the whole vertical and the whole horizontal are not equal, but the whole meridians are the same. يعني all the vertical is the same power, all horizontal is the same power. But if the lower half or the upper half alone is not equal to the other half of the same meridian, is called irregular astigmatism, and this is the difference. طب what's called with the rule and against the rule means that vertical is steeper than horizontal but equal. Irregular means with the rule astigmatism. Where against the rule is the reverse, means that the horizontal is steeper than the horizontal. What's the common؟ ايه الكومن اللي بنشوفه في حياتنا مع البيشنتس بتوعنا؟ لا, with the rule astigmatism is the common. So against the rule is minimal, is fewer, is much fewer than with the rule astigmatism, ومش معتادين نشوفه كتير. Oblique astigmatism. What's the meaning of oblique astigmatism? Means that the vertical and horizontal are not they are perpendicular all the time, but not at the 90 and 180. Could be perpendicular, but at 35 and 145. It's called oblique astigmatism. لكن الsymmetrical والcommon ان تلاقي vertical at 90 degrees والhorizontal at 180 degrees. How to treat the astigmatism? First of all, you have to know the type, regular ولا irregular, with the rule ولا against the rule. خليني أقول لك another words. The problem in the refraction in this is the presence of or the formation of multiple foci, many foci in front and behind of the retina. So there is what's called conide of Sturm. Conide of Sturm. Sturm اللي هي storm, STORM, and you know that the storm is the winds and with turbulence and with uh, it's not nice, it's not regular, it's not wavy winds, but it's turbulent waves and turbulent winds. So it's called the same, conide of storm. It's a Latin word again, but means that there is fuzzy, there is noise in the vision. يعني in Arabic words كأنها عاصفة، كأن في عاصفة ترابية موجودة قدامك. And you will see the vision in front of your eye like if there is a wind or storm. Okay. فعشان كده اسمها conide of storm. ده تعبير عن الفصاي, multiple foci with a noisy and blurry vision. So the image will be blurred and will be um, uh, will be I need the accurate explanation. It's called what excuse me, mental block يا جماعة. Yeah, distorted image. You will see that the image is going to be dancing, will be hesitating, and will be distorted. يعني تشعر كأن الإيمج إنها waving أو dancing، إنها معوجة أو بتتحرك قدامك. هو ده البيشنت complain. The patient's complaint will be in the same words. Will see, doctor, I'm seeing the objects, but actually I'm seeing the objects like running or like dancing or like hesitating or like distorted or like distorting يعني ايه؟ يعني كأن في كينك، يعني في اعوجاج في الصورة بيجي ويروح. هو دي كل دي الاكسبلانيشنز اللي بيقولها الاستجماتيك patient. How to correct? Here it's complicated. It's somewhat more complicated than myopia and the hyperopia. Because of what? Because you don't have one axis. You don't have one meridian. You have vertical meridian with power and horizontal meridian with another power. So it's called cylindrical error. So you need glasses with cylindrical lens. Cylindrical lens means you will correct vertical meridian with a power and horizontal meridian with another power. So it's called toric lens. Toric lens means that it's not totally convex or totally concave, maybe both together to form what's called toric lens. Okay. يبقى الكوركشن بتاعها cylindrical lens or toric lens. اللينس ممكن تبقى spectacles يعني glasses او ممكن تبقى contact lens برضو، بس مش rigid lens عشان ما نروحش بس مخنا نروح للrigid lens. الريجيد lens دي موجودة في irregular astigmatism مش regular astigmatism. انا لسه still talking about the regular astigmatism. Okay, or ممكن برضو by laser, by ablation of the all meridians. I will correct the all meridians according to the curvature of each meridian. يعني I correct the steeper أخليه flat أو correct the flat أخليه steeper. Okay, to be equal. Going to reshape the cornea to be with equal power. في الامبلانتيشن inside of the eye there is what's called toric ILs. Toric ILs, spherical IL with added toric curvatures to correct the astigmatism according to the power. So what about the regular astigmatism? I told you that the regular astigmatism, the regular astigmatism is totally different than the regular. It's it's mainly or it's totally pathological. It's not normal. The astigmatism doesn't mean pathology. The astigmatism itself, when regular, does mean error of refraction, like myopia and hypermetropia. So no problem. You can no problem. You can correct with the other means. But the irregular astigmatism is totally different. It's pathological due to corneal scar or what's called keratoconus. Keratoconus, it's an inherited or genetic disease leading to weakening of the corneal stroma with change in the direction and the integrity of the cornea, causing prolapse or bulging of part of the cornea. البالج او البرولابس اللي بيحصل في الكورنيا ده بيعمل irregular astigmatism at the area of bulging cornea. So I need to correct. By laser, it's not suitable. By lens, it's not suitable. So the glasses is limited because the glasses will correct the total power, not this focal change. So the main way to correct the keratoconus at your level as an undergraduate by rigid contact lens, not soft, because the soft will take the contour of the cornea and the contour is irregular, so it won't be able to correct. But I need what's called a rigid contact lens or hard contact lens, because the hard contact lens will keep its curvature all over the cornea, so it will correct the refraction power but keeping the surface regular. أنا بحط rigid lens on a regular cornea but it's regular lens, so it will equalize the power all over the cornea as if I put a new cornea. uh, I hope it's understandable. But in advanced cases, when I need to change, when I need to treat the keratoconus, I need to do keratoplasty. Keratoplasty means I will remove the cornea and and implant another cornea to substitute this pathological cornea. So I'm going to correct the keratoconus by this way. I hope it's understandable to all of you. What I have said in the previous um, slides are the most important types of errors of refraction and how to diagnose and how to correct as well. Finally, aphakia, absence of lens. aphakia when I ask you what's aphakia هتقول لي الاكسبريشن بتاعها بس هتقول لي optical definition. Aphakia means absence of lens. It's the anatomical definition. What's the optical definition? A severe type of hypermetropia. No lens. So decreased power. صح؟ decreased power بتساوي hypermetropia. ولكن aphakia and I removed around 17 to 20 diopters of the refractive power of the eye. But very low power, so very high hypermetropia. Okay, types of correction. lens هتقول لي الطيب طبعا انت عارفينه كلكم دلوقتي انه convex lens but high convex lens اسمها high plus lens with its aberration and its fuzzy appearance. Contact lens also by implantation which aphakia means absence of lens, so I will implant lens inside of the eye. So these are the information needed for aphakia. Maybe congenital aphakia is rare. Maybe after surgery, yes, a lot. After surgery, especially in the congenital cataract, I remove the cataract with no implantation of the lens, so the patient or the child will be aphakic. Or incomplete surgery, removed the lens in adult, but I didn't implant IL, so intraocular lens, no, not present, so there is aphakia. Okay, or traumatic. After trauma, the lens will be displaced or dropped into the vitreous, so it's aphakia. Presbyopia, طبعا I told you about definition, it is recession of the near focus of the eye. أو أو definition الcommon اللي هو general definition inability of the person after the age of 40 to see the near objects because recession of the near focus of the eye due to decreased power of accommodation. It causes age related mostly. All of us after this age will be presbyopic. It causes another causes debilitating disease with generalized weakness, so the accommodation power is muchly decreased. So there is early presbyopia. So presbyopia is a normal age-related status happening after the age of the 40, but in 40s, maybe 41, 42, 45 in some patients. So, but no sharp time, but all is all are having. Okay, management هو inability the two weakness means less power صح. So the management will be adding power by which kind of lens, convex ولا concave? Convex طبعا. Okay, يبقى reading glasses by convex lenses. Contact lenses, yeah, multifocal lenses, maybe bifocal lenses, maybe bifocal for far and for near, or multifocal for far for the intermediate and the for near distances. And we have nowadays intraocular lenses to correct presbyopia. But at your level, reading glasses with convex lens and no more. If you like to add maybe convex lens is reading or bifocal or multifocal or laser ablation to make the cornea as a bifocal lens or by implanting multifocal intraocular lenses. I told you about the optical and surgical ways of correction of presbyopia. I have finished now, and I hope it was clear and well, not boring lecture. And thank you so much. So I'm able now to address your questions if you have. شباب,
شكرا
Thank you
حضرتك.
دكتورنا. شكرا دكتور.
most welcome. أهلا وسهلا بيكم. يا رب تكونوا استفدتوا. دي recorded.
المحاضرة
عبد الرحمن recorded.
يا دكتور إن شاء الله.
طيب استأذنك لو ينفع تبعت لي ريكورد بتاعها.
من عينيا يا دكتور.
حبيبي. طيب عاوز بس اقول لكم على حاجه. لو انتوا معايا دلوقتي انا ليا اوريدي يوتيوب تشانل، عشان لو حد حب يراجع المحاضره تاني. في يوتيوب تشانل اسمها زياده اي اكاديمي. زياده اللي هو الاسم بتاعي ZIADA، وبعد كده IEYE واكاديمي، موجوده على اليوتيوب. عليها ايرورز اوف ريفراكشن موجوده بطريقتين، يعني انا قايلها مرتين. هتلاقي طبعا محاضرات كتير، اندر جرادويت بوست جرادويت وفيديوهات اللي هي لشغلنا يعني. بس هتلاقي في انا معلم على محاضرات معينه اندر جرادويت فيها ايرورز اوف فراكشن، وفيها هايبرتنسيف ريتينوباثي، وفي انفكشنز اوف ذا اي، وفي ريد اي، وفي حاجات لو تحبوا تراجعوها موست ويلكم. وطبعا يعني يسعدني ويشرفني ان انتوا تعملوا سبسكرايب على التشانل بتاعتنا. شكرا جزيلا، وكل سنة وانتم طيبين، وتصبحوا على خير إن شاء الله تعالى.
عليكم السلام يا دكتور.
السلام عليكم.
عليكم السلام.
مع السلامة.